after we loosened up a little bit, we can have the best presentation. So we'll start first with Elizabeth Yonko, whose presentation is titled Associations Between Discriminatory Attitudes, Knowledge, and HIV Testing in Lesotho, Malawi, Tanzania, Zambia, and Zimbabwe Results from Population-Based HIV Impact Assessments. And we'll allow each participant 4 minutes for their presentation and about a minute for questions, but they can use their 5 minutes as they please. Elizabeth, take the floor.
Thank you. So I know posters can be hard to see over Zoom, so I just dropped a link in the chat to my poster if you want to look at anything more closely. So my name is Elizabeth Yonko. I am a second-year MPH student in the epidemiology department with a certificate in infectious disease epidemiology. This past summer, I worked with Tom Carpino, Andrea Lowe, and Kay Yingling on the FIA data analysis project, and I'm continuing work on this project for my thesis. So I focused on assessing associations between HIV-related knowledge, discriminatory attitudes, and testing behaviors in Lesotho, Malawi, Tanzania, Zambia, and Zimbabwe. The study population consisted of approximately 67,000 adults ages 15 to 59 who responded to the population-based HIV impact assessment surveys between 2015 and 2017. And due to availability of data from a specific module in the FIA surveys, only the 5 countries I listed were included in the study. In my literature review, I found that stigma and discrimination towards people living with HIV are barriers to achieving the UNAIDS targets for HIV testing, treatment, and viral suppression. Some studies found that improving HIV-related knowledge and testing could potentially mitigate stigma and discrimination towards people with HIV. For my analysis, I ended up conducting a chi-squared test and creating 2 multivariable logistic regression models containing confounders and covariates identified through my literature review. So you can see here in table 1, the variables that I included in my models. So the main outcomes which I created the models for were HIV-related knowledge and discriminatory attitudes. These were both binary recoded variables based on participants' responses to specific survey questions meant to capture these constructs. So figure 1A in the bottom left-hand corner shows differences in knowledge and discrimination by country. So as you can see, Tanzania had the highest prevalence of discriminatory attitudes, and Lesotho had the highest prevalence of insufficient HIV-related knowledge, which is interesting because Lesotho also has the highest HIV prevalence. So this country might be a good target for interventions that improve HIV-related knowledge. And figure 1B just below shows knowledge and discrimination again by HIV testing status, which was included in the logistic regression model as a covariate. And you can see that people who reported never being tested for HIV or not knowing whether they've ever been tested for HIV had the highest prevalence of both insufficient knowledge and discriminatory attitudes compared with participants reporting their status as either HIV positive or HIV negative. And so as I previously mentioned, additional results from the regression models can be seen in table 1, and all significant results in the final adjusted models are bolded in red here. So I also want to take a moment to discuss some limitations from my study. Because this is a cross-sectional analysis, we can't determine temporality, but the associations we see are certainly interesting and can be used to generate additional hypotheses. And another limitation was that there were some variable mismatches between countries. I was able to recode some of the variables to match, but because of this issue, not all variables identified in the literature review were able to be included in the larger final models. So as I previously mentioned, I'm continuing this project for my thesis, and I'm taking a GIS class this summer and hoping to include a small spatial sub-analysis looking at how these outcome variables of knowledge and discrimination map against HIV prevalence in these countries. So I'd like to end by thanking Andrea, Tom, and Kay for their support, and thanking all of you for joining this session today.
Great. Thank you, Elizabeth. So we have about a minute to open the floor to questions if folks have questions for Elizabeth. Okay, then let's keep it moving and we can come back to questions later. So next
Oh, sorry, can I just ask real quick? Sorry.
Yes, please.
The mute button.
Yeah.
Elizabeth, that was beautiful, first of all. And I'm sorry, I was distracted for 1 minute by somebody coming in, but did HIV knowledge, what was included in that?
So there were 5 questions in, I think it's module 6 on the FIA surveys that ask questions about how you can transmit HIV. One example is, I think while grocery shopping, can you get HIV from a vendor who's HIV positive? That's an example of one of the questions. Or can you get HIV from a mosquito bite? And if participants answered any one of the 5 questions wrong, they're coded as having insufficient HIV-related knowledge. And that's from guidelines from UNAIDS.
Oh, wow. Okay.
Yes.
That's really interesting. And this discrimination, is that also like a few questions?
Yeah, it's a few questions like, would you send your child to school knowing that someone is HIV positive? That's not exactly the question, but I can't remember word for word off the top of my head.
Yeah, no, really interesting, especially your figure 1A, I find really interesting. With the, Lesotho, being so high on the insufficient knowledge with such high rates of HIV in that country. It's really remarkable. Yeah.
Definitely. I hope to parse that out more with my spatial analysis.
That would be great. Thank you very much.
Thank you.
Thank you, Elizabeth. Great presentation. So next we have, thank you, Yale, for your question. Next we have Leslie Green, who is presenting her presentation titled ICAP 2030, the diversification and decentralization of ICAP's donor portfolio. The floor is yours.
Hello, everyone. Okay, can everybody see my screen? Okay, awesome. So hello, everyone. My name is Leslie Green, and I'm a Master's of Public Health candidate at the Mailman School of Public Health. This past summer, I worked with the planning and development team at ICAP on a global health funding project titled ICAP 2030, the diversification and decentralization of ICAP's donor portfolio. So just some background on the project. ICAP's funding for their multitude of projects and programs comes from 5 main sources: US government affiliates, private corporations and foundations, Columbia University, bi and multilateral organizations, and major gifts and donations. Over 80% of ICAP's funding is based in the United States, and almost all of this funding is secured by a team in New York City. So as part of ICAP's organizational strategic plan for the year 2030, one of the main priorities that was identified was the diversification of these funding sources, specifically outside of the United States, into 2 areas of interest: Sierra Leone and the Central Asia region, which includes Kazakhstan, Kyrgyzstan, and Tajikistan. So as a next generation fellow with this project, my role was to examine the current landscape in each of these countries and explore ways to engage new private donors in each of the local contexts. So the project took a 3-part approach. In part 1, we conducted a landscape analysis in each of the countries, reviewed the past and present programs, their implementation partners or current donors, and this was all in an effort to identify priorities and gaps in the current health programming in each country. And this was really to provide a framework upon which to create a landscape analysis tool that's incorporated into part 3 of the project. And then in part 2 of the project, we conducted a desk review of local private corporations and foundations in the countries of interest that would align with the priorities of ICAP. And this, similar to in part 1, provided a framework upon which to base the creation of a donor exploration tool that's incorporated into part 3 of the project. And then finally, in part 3 of the project, we used the tools and methods that we created, the tools and methods that were already present in ICAP's portfolio, as well as evidence, suggestions, and lessons learned from experiences of ICAP employees finding and fostering private partnerships in the countries in which they operate. And we put it all together to create this resource guide on in-country private sector engagement. So the main outcome of this project is this resource guide for in-country private sector engagement for the ICAP country offices outside of the United States. And this resource guide breaks down the process into 3 key phases: the discovery phase, the engagement phase, and the agreement and award phase. And each phase really offers best practices and guidance that country teams can use and adapt to fit their own unique context themselves. The resource guide includes tools like pitch decks, capacity statements, email templates, the landscape and donor analyses tools that I mentioned prior, as well as a template for budgeting. And it also provides direct action steps that each country office can take to pursue private sector donor discovery and engagement in their own local contexts. So as for future directions and implications of this project, after the dissemination of this guide to country offices internationally, as well as its subsequent use, we would hope that the country offices would come together in the form of skills-based labs and really practice using the methods and tools outlined in the guide and practice business development skills like donor engagement and relationship building. They can share what has worked, what hasn't worked in their own settings, attempt to replicate what has worked in different contexts. And as time progresses, we would hope that the best practices would be further incorporated back into the guide and reflect this ever-evolving and iterative nature of the guide. And ultimately, by disseminating this resource guide and continuing the business development of the ICAP country offices outside of the US, we would hope to strengthen the local capacity of those offices and the leadership to identify and engage donors locally and build out their own donor portfolios. And we really think that this capacity strengthening is crucial in the work towards decolonizing the global health aid structure, and it could be transferable to other countries. Thank you.
Thank you, Leslie. That was great. And I feel like every time I hear it, I learn more and more about your project, which is awesome. Does anybody have any questions for Leslie?
I don't have a question. I just have a quick comment though. So Leslie, I was involved in the ICAP 2030 vision and putting it all together. So it's just wonderful to see it being kind of implemented, not only implemented, but also evaluated and, you know, with and creation of tools to help with the implementation. So it's really, really nicely done. Thank you.
Thank you. Yeah, it was a great project to be a part of, and it really kind of evolved over the course of the summer into ultimately this resource guide. So yeah, I'm very happy to have been a part of the process.
Who did you work with?
I worked with Sarah Parrish for the most of the summer before she left. And then for the last, I would say like 2 weeks, I was with Christine Hunt.
Okay, got it. Yeah, great.
And just to say that we've already used this in starting some of our, kickstarting some of our newer country programs. And I think, you know, it's going to be a live document as we expand the breadth of our funding sources. You know, I think we learn more on how to work with different donor environments and in different countries. So this has been a really great addition to our work. So thank you for working on this.
Oh my goodness, that is so good to hear.
That's wonderful.
So
Yeah, that's really awesome to hear, Leslie. Okay, so next up we have Haley Silverman, who will be presenting on her thesis, Patient-Centered Care Project, PCCP.
Hello, everyone. I'm Haley. I am an MPH candidate at the School of Public Health, and this summer I worked on the Patient-Centered Care Project, or PCCP, with my mentor, Dr. Joanne Mantell. So some background on PCCP. It was a qualitative research study with the goal of identifying the most relevant, salient, and influential factors to uptake and use of HIV testing and care in Western Kenya among fishing and non-fishing communities in 3 counties, Siaya, Kisumu, and Homa Bay counties. The population was men who have sex with men, heterosexual men, and young women. And the 3 cohorts in the study were HIV negative or status unknown individuals, HIV positive in care, and HIV positive out of care. And so when I was brought onto the project this summer, the data had already been collected and had been coded in Deduce. And so I was brought on to assist in the writing of the manuscript specific to HIV testing. And so I was really focusing on this HIV negative and status unknown cohort. And so these tasks that I included here are both these first 2 are the overarching goals of the project that I was brought on to assist with, and then the following tasks are how I accomplished those goals. And so I conducted a literature review. I read through a lot of the transcripts. I learned how to use Deduce, and I downloaded the code reports. And most of my time was spent writing up the themes and drafting an abstract based on those results. So this is a bit hard to read, and I will try to explain it the best that I can. This here is a little example of, it's just a zoomed in part, so you can get a little bit of an idea of what was on this document. But this was originally an Excel spreadsheet, and each row is a different theme that I identified through analyzing the coded data, and that were the most important factors in specific to testing among HIV negative participants. And then each column is divided into the three populations, the MSM, heterosexual men and young women, and then also further split into fishing and non-fishing communities, and color coded based on the county that they were from. And so then I read across the all of the rows, and I created these little post-its here at the end that you can see, and that was kind of a summary of the most consistent, important themes that appeared across the entire row. I also made note of if there were certain themes that came up specifically to one group or specifically to another. I also made those notes of those, so they were essentially a little bit of a summary. And then these other little stickies I used. So stigma was an extremely important theme that came up, and so it was really significant and had its own theme for which I analyzed all of the populations, but it also came up as parts of a lot of other transcripts. And so I used these red sticky notes to denote where stigma came up among other themes, but was still more important to that original theme, but still had to do with stigma. So that's what these red sticky notes denote. And then the pink ones were very interesting or very unique information that I found from the transcripts that I found might be important to the larger study. And so some examples of results, the first is on testing experience. And so testing experience was further delineated into positive and negative experiences based on what we read in the transcript. So this is just an example of a quote that essentially the interviewers asked me, how did the testing go? And they said they were patient, I was welcomed, and I was encouraged. And that is obviously a very positive experience. And then some barriers, just quickly, fear is a major barrier to getting tested. There's fear of actually being HIV positive, but also of other people knowing that you tested, that you questioned your status at all, among other things, or being recognized by community members or healthcare workers. And so those are some barriers to testing. And so some conclusions is that, to our knowledge, this is the first study that compared all of these populations at the same time among fishing and non-fishing communities. And what we found is that overall, there were not many differences that were specific to fishing or non-fishing communities. And we attribute that to the fact that since it was from the three counties, the fishing and non-fishing communities are contiguous. And so it's not exactly clear where the delineation is between the fishing and non-fishing communities that could have impacted the results. Additionally, as I mentioned, stigma was a very salient issue. It came up under the theme of condom usage, testing attitudes, testing experiences, and also the recommendations that participants made to improve testing. And then some reasons that participants chose to get tested is because they wanted to know their status, it's free, it's convenient, and they have positive experiences when the facilities are convenient, confidential, and the staff is friendly and warm. So thank you so much for listening.
Thank you. Okay, so unfortunately, we don't have time for questions. We have one more presenter who couldn't join us in person, but they have sent us their video. So I am going to share my screen and we can watch this 4-minute and 15-second video. If I can figure out how to use Zoom. Okay, great.
Hi everyone, my name's Dee. Sorry I can't be there in person with you today for the poster session, but I've recorded this video to tell you about the work that I did with the Strategic Information Unit last summer. So I looked at social cohesion and HIV testing among men who have sex with men in Zimbabwe. So to give a bit of background, men who have sex with men, or MSM, in sub-Saharan Africa have a higher burden of HIV as compared to other adult men. So to address this high burden of HIV, UNAIDS set care cascade targets, and you can see an illustration of the care cascade on this slide. So the goal was that by 2020, 90% of all HIV positive individuals in a given population would be aware of their status, and 90% of those aware would be on ART, and 90% of those on ART would be virally suppressed. Unfortunately, these targets were not met in Zimbabwe. As of 2019, just 35% of MSM in Harare and 53% in Bulawayo were aware of their status, highlighting a need for interventions that promote HIV testing. So recent studies have indicated that social cohesion, which is a measure of mutual aid, trust, and solidarity among MSM, is an important factor that can promote engagement in the HIV care cascade, including promoting testing. So the aim of this analysis was to examine the relationship between social cohesion and HIV testing in the last 6 months among MSM in Harare and Bulawayo. So data for this analysis comes from a cross-sectional biobehavioral survey that was conducted from March to July 2019 in Harare and Bulawayo. There were a total of 1,538 participants enrolled, 738 from Harare and 820 from Bulawayo. Social cohesion was measured using 4 different survey items regarding trust, support, and solidarity within the MSM community. In order to identify potential confounders, we used a relative risk regression to assess the association of sociodemographic variables, sexual risk behaviors, and stigma variables with social cohesion and HIV testing in the last 6 months. These variables were identified based on prior knowledge and the literature. We made an a priori decision to include age and fit multivariable models to examine the relationship between social cohesion and HIV testing in the last 6 months, adjusting for potential confounders. So in our analysis, we included 354 MSM from Harare and 528 from Bulawayo. The prevalence of high social cohesion was 31.1% in Harare and 67.2% in Bulawayo. There were no variables found to be potential confounders, so in our multivariable model, we only adjusted by age. So here you can see the estimated prevalence ratios of HIV testing in Harare and Bulawayo. You'll see that the unadjusted and adjusted rates are quite similar. So in Harare, it appeared that there was no significant association between social cohesion and HIV testing, whereas in Bulawayo, it appeared that those with higher social cohesion were actually less likely to have been tested in the last 6 months. So these results are in contrast with what we were expecting to find based on prior studies that have found social cohesion to be positively associated with HIV testing. So the unexpected results could be due to our inability to adjust for other potential confounders such as social participation, which have been adjusted for in previous studies. And additionally, the social cohesion items that were used in the survey haven't been validated in Zimbabwe and so are perhaps not actually measuring the social cohesion construct. So we suggest a future study validating these survey items in Zimbabwe. So thank you so much for listening. Sorry I can't be there to answer any questions, but hope the rest of the day goes well.
Great. And that was, again, Dee Wong with her presentation titled Social Cohesion HIV Testing Among MSM in Zimbabwe. And I just want to thank all of our scholars again for such lively presentations. And I hope you guys have a great weekend.